Thank you so much, Steve, for having me for this morning, afternoon, evening, everywhere in the world. And I'm glad to be with you, all colleagues, people who are interested in cardio-oncology. My name is Zaza Iakobishvili from Tel Aviv, Clalit Health Center, and I'm doing cardio-oncology during the last 7 years. And I think it's a wonderful thing. Can you mute yourself, please? And I want to discuss with you the presentation of the patient that I think is very important for us, for cardio-oncologists, to be sure that we are on the same page with our oncology colleagues. So we'll discuss the case of pericardial effusion in advanced lung cancer patients. We're talking about 67-year-old male, he never smoker, hypertensive for 20 years, controlled on ACE inhibitors and calcium channel blockers. He was physically active and fit, and he get his only medication, additional medication for gout prophylaxis, colchicine, or 0.5 milligram per day. In 2015, he was presented with dry cough to his family physician, and after quick workup on chest CT, he was diagnosed with bilateral lung space-occupying lesion with large right pleural effusion and large pericardial effusion. What you see here on the right side, it's not his CT, PET CT, but it's only for this illustration. I wasn't able to get back his original CT scans. So because of this, you cannot see the real pictures. Transbronchial biopsy of this patient identified non-small cell squamous adenocarcinoma of the lung with liver and bone spread by PET CT. And tumor tissue analysis revealed ALK mutation. And the patient was referred for cardiology consultation due to his pericardial effusion. On physical examination, he had normal blood pressure, as you can see here. He wasn't tachycardic, a little bit tachycardic, 84 beats per minute. His normal saturation, 98% in room air, without any distress. But on physical examination, we were able to examine large areal dullness over right lung, consistent with pleural effusion. And no signs of tamponade were detected. This is his EKG. As you see, it's right bundle branch block with left anterior hemiblock, normal sinus rhythm, as I said, about 20 beats per minute. And it doesn't support diagnosis of pericardial tamponade. We cannot see any real variation, respiratory variation of QRS. So there is no electrical alternance. And here you see the echo that was done the day before his admission. In parasternal long axis view, you can appreciate echo-free space around the heart. You can see that in parasternal short axis view as well. And this is his four-chamber view. You see normal contracting heart, a little bit hypertrophic. You remember that the patient is hypertensive. And he has a lot of fluid. Actually, it's some kind of swinging heart, as you can imagine yourself. And even we had here some mitral flow variation, respiratory variation. So there is echocardiographic signs which may be consistent with tamponade, but the patient clinically was not in tamponade. He was with normal blood pressure without any evident distress. And as all we know, tamponade is a clinical diagnosis, and he was treated as a patient with large pericardial effusion, actually asymptomatic. Sorry. So the patient at this point was offered to undergo video-assisted thoracic surgery for a thoracoscopy for pleural replacement. It's kind of catheter, you know, for continuous drainage, and creation of pleuropericardial window. The patient refused the window and agreed only for continuous pleural drainage. In this case, you remember the patient was ALK mutation positive, and he was initiated on crizotinib. It's a TKI inhibitor. And after 3 months of treatment, near complete response was obtained according to PET-CT. The patient still remained with prolix with day drainage of huge amount, about 300, 400 cc of pleural fluid. Pericardial effusion decreased gradually during the period of half a year on crizotinib. At 2018, brain mets were detected on MRI, and stereotactic surgery was performed and treatment was changed to brigatinib with excellent results. At 2020, routine echocardiography detected small pericardial effusion. You will ask why routine, and I will explain it later on. And follow-up MRI detected new brain mets, and the patient was switched to the newest drug in the field, lorlatinib. Here you can see his echo. In January 2021, PET-CT detected large pericardial effusion, and echocardiography and clinical assessment, there was moderate to large pericardial effusion without signs of tamponade. You see pericardial separation of 27 millimeter in the short axis view. The patient again was offered by us to undergo thoracoscopy for creating pericardial window, pericardial biopsy, and sampling the pericardial fluid for repeated genetic analysis. He again refused the surgery and preferred carboplatin pemetrexate combo chemotherapy. After 3 cycles, pericardial fluid regressed to small to moderate amount, and he feels weak. I saw him actually yesterday, the day before yesterday. He felt not so bad on his own leg, and it's this echo examination from the day before, 2 days ago. So now we have dilemma here. I want to present to the panel of my colleagues. We're today joined by our team oncologist, Dr. Elizabeth Dudnik. She is senior oncologist in Rabin Medical Center, Davidoff Cancer Center, and Professor Dan Gilon is senior cardiologist, well known for his echocardiography work, and he's cardio-oncologist also with a lot of experience. And we'll be discussing the cause of pericardial effusion. Maybe it's micrometastasis, undetectable by PET-CT and other imaging. Maybe it's drug-related, lorlatinib, or even we're talking about non-cancer related usual causes of pericardial effusion like viral and other causes. If we look at the Vita textbook of Cancer Principles and Practice of Oncology, last edition, you see that in the chapter of systemic management of patients with stage 4 non-small cell lung cancer, we have a lot of things to do. First of all, this algorithm advises to look at immuno and molecular testing. Immuno and molecular testing are doing, all patients will undergo PD-L1 testing. All non-squamous cell patients should be examined for EGFR, ALK, ROS1, BRAF, and other mutations. And if it is squamous histology, we have to consider also to do molecular testing. If there is no targetable mutations, this goes according to PD-L1 expression. And I won't stop on this side because our patient was ALK mutation positive. He was treated, as we all heard before, by crizotinib and later on alectinib and brigatinib. So actually right now we are here at this algorithm. The patient was switched from brigatinib to another drug. He has brain matters. He has some regression of his brain matters, and now he is treated by platinum doublet. And plus or minus bevacizumab, it's in discussion between oncology team members with his neuro-oncologist and treating oncologist. Actually, why we're talking about so much for advanced lung cancer patient with pericardial effusion? In 2002, when this paper was published, as you see, survival of these patients was dismal. You see that about only 5% of these patients survived 5 years. But during the last 20 years, we are actually seeing the revolution in the field of oncology with the introduction of immuno-oncology therapy. You see here, for example, pembrolizumab combination compared with placebo in Keynote 189, and you see that the survival of this patient increased very significantly. If you see about target mutations, if you look at target mutations, a patient with oncogenic driver mutation who did and did not receive targeted therapy, those who received targeted therapy had excellent, better survival, far better survival than patients without targeted therapy, no driver mutation. So targeted therapy with TKIs and immuno-oncology really changed the prognosis of this patient. And because of this, as Niels Bohr said once, prediction is very difficult, especially if it's about the future. I would add of lung cancer. Now we do not predict the real survival of lung cancer patients because there are a lot of new drugs, and every other month we have another paper in leading journals that's showing that there is more and more options for these patients. So our approach to this patient has to be changed, I mean cardiologists, because if at the beginning of my career, at the 2000s, when we had a patient with advanced lung cancer and pericardial effusion, stage 4 disease, it was only, like end of the game situation. Now it's another situation. Now we have to make differential diagnosis, cancer versus non-cancer related causes. And cancer-related causes, there are a lot of cancer-related causes. First of all, if we're talking about pericardial metastasis, actually according to this paper from Clinical Cardiology, only 15 or 20% of them will have pericardial effusion. If we are talking about anti-cancer medication related pericardial effusion, immunocheckpoint inhibitors are causing that in 0.5% of the cases. TKIs causes in relatively big numbers. You see, ceritinib causes it in 5.8%, osimertinib 0.6%, and about lorlatinib, there are few case reports. There may be pericardial effusion due to chest radiation in about 15 to 25%. So there are a lot of causes, and we have to elaborate on these causes to be able to treat the patient according to the treatable causes. We have done some work in this field, and this work is submitted to publication. Dr. Nadia Agmon, very young and energetic cardio-oncologist from Rabin Medical Center, with collaborators, and looked at the database of 1,000 consecutive lung cancer patients who attended the thoracic oncology unit at Davido Cancer Center in 2010-2016, and she identified 15 cases of large hemodynamically significant pericardial effusion. 67% of the patients were female, and 93%, had non-small cell lung cancer. Most of the patients had stage 4 disease, and it's very impressive that about 50% of them had EGFR or anaplastic lymphoma kinase, ALK mutations. 30% of patients, 20% of patients were treated by targeted therapies when large pericardial effusion was diagnosed. All of them had negative pericardial fluid cytology. And pericardial effusion in these cases was managed by targeted therapy dose reduction, knowing that some drugs may cause pericardial effusion. 12 patients, 80%, were diagnosed with pericardial effusion before initiating any anti-cancer therapy. According to this small study, we had some conclusions that actually, in the most of the cases, the patient underwent surgical treatment by creating pericardial window, which allows more definitive management of preventive recurrence, and that can allow functional recovery and opportunity to subsequent anti-cancer therapy with improved survival. And in 3 of our cases, no malignant pericardial effusion may be a side effect of anti-cancer treatment. So we have to differentiate between cancer-associated with cancer-related pericardial effusion. And high index of suspicion is needed to look for early detection of pericardial effusion. Because of this, it's my rule to follow these patients with pericardial effusion even after treating the pericardial effusion by echo examination, routine echo every 3 months. If you look at this study, which was published in Cardio-Oncology 2 years ago, it's a French study. They looked at their local database and identified from 310 pericardial effusion patients, 68 with malignant pericardial effusion. And 44 of them were treated by percutaneous pericardial synthesis, PPC, as you see here, and 24 surgery. Lung was primary cancer in 49% of patients, and breast 18%, and digestive tract of 15%. As you see, there is no difference according to the mode of treatment. I mean, percutaneous treatment was as good in terms of survival as surgery. Another interesting observation was published from South Korea a few weeks ago in Journal American College of Cardiology. They looked at their local database, and actually they showed that successful pericardial synthesis by catheter-based was, they were able to do this in more than 96% of patients. They had quite a large amount of adhesion without and with constriction, and recurrent effusion they observed in 26% of patients. But they looked at the treatment, concomitant treatment of the patients, and it's interesting that administration of colchicine, that we know from the field of non-malignant pericardial effusion as the must drug for prevention of recurrences, had some survival advantage in this retrospective observational study. You see that patient with colchicine treatment has lower death rates and lower death recurrent pericardial synthesis, pericardial window formation. You see p-value is significant in all those cases. So, in summary, pericardial effusion in non-small cell lung cancer at 2021 is not end of the game, especially if the patients are eligible for targeted therapies and immuno-oncology therapies. Multiple etiologies, cancer therapy related, cancer related, and non-cancer causes need to be fought. Adenocarcinoma with driver mutations probably needs routine echocardiography follow-up for early detection and appropriate management of pericardial effusion. And treatment options depend on local expertise and anatomical characteristics. I'm very excited about the South Korean study, and I think there is an urgent need to set up prospective trial of anti-inflammatory agents, colchicine, for example, for the management of cancer-associated pericardial effusion. I thank you for your attention, and the talk is open for discussion. Professor Gilon, please, your thoughts.
I have a question. Have you had any experience, or have you done any infusion in the pericardium of a sclerotic agent such as methoxydraine or bleomycin or something like that?
So actually, this needs this kind of treatments are very accepted in Italy and Europe and in some other countries too. In Israel, actually, we do not do that because this kind of treatment were connected with complications rate not so, and I think maybe there is some other things we can do better, but using this kind of drugs, I think at least we do not have any good studies, good data to use and to prefer this kind of approach compared to surgery or conventional pericardial synthesis. What do you think, Dr. Dudnik, about this? Using some kind of chemotherapy, intrapericardial application of chemotherapy, or other drugs?
Can you hear me? Hello, everyone.
Yes.
I'm Elizabeth Dudnik. Thank you. No, I'm not familiar with using invasive technology as in lung cancer patients. But we have nowadays much better drugs. I just wanted to emphasize what's already been said. The prognosis of lung cancer patients has changed dramatically with the introduction of new biologic agents and also immunotherapy. For instance, the median overall survival of patients where the ALK rearrangement, this has been metastatic disease, nowadays it exceeds 5 years. And talking about patients where the EGFR mutant tumors, we are talking about the median survival of 3.5 years. So probably the better strategy for these patients, present them with metastatic disease and malignant pericardial effusion, for the patients that are harboring any targetable abnormality, as doing some pericardial synthesis or pericardial drainage, pericardial window, and start a biological treatment. It's the best strategy, and we're pursuing this in our everyday clinic.
So Zaza, this is the other Dan. So appreciate your presentation, and I think this is a very interesting topic in many ways, and I think that the general plan has probably changed over the last decade, kind of consistent with everything else. But one comment that I would make about the colchicine that you showed the paper about it, there are several points that I would make about that colchicine data. Number one, it was certainly not randomized, and so really they were looking retrospectively at their own data, and they decided as an institution or a group of institutions, they decided to use colchicine. And so you don't know the biases that exist. And so I think they may have only chose to use colchicine in those people that were generally healthier. So, I don't know that. I'm just saying that you don't know the biases there. And then the other 2 points is, if you look at the table that makes up that paper, the group that had malignant pericardial effusion had a worse outcome when they were treated with colchicine. So it wasn't statistically significant, but it was suggested by the data. So they had a pericardial effusion, and only those that had true malignancy in their pericardial fluid were the ones that didn't really benefit from colchicine. So I think that you have to be careful about the details there. And then the other part is that, there's a modestly significant incidence of aplastic anemia and pancytopenia related to colchicine. And so in this population, they only looked at solid tumors. They didn't look at hematologic malignancy. So in people with hematologic malignancy that have a pericardial fluid that needs to be tapped, I would give some pause to using colchicine in that population. So I think I would, and only because you don't want to exacerbate an already significant pancytopenia picture. So.
I agree with you. Thank you for your comment.
I'd like to bring up a question, or maybe even two, regarding beyond the just lung cancer. One is, first of all, about what you said, follow up every 3 months. Even if I agree, which I do, is how long do you go with those 3 months follow-up if there's no change? That's one question. The other one, these cases where I think overall were clearly very well managed with good results, but they came along with the flow chart, which is reasonable and published. My question, if you get like real life, more complication issues, such as I think you had, I'm sure you had, all of you, and so did we, if the patient has metastatic disease, possibly from the lung, but not only, and then develops what is not uncommon, pulmonary emboli. What do you do if you have pericardial effusion? Okay, you took it out, it was bloody. What do you do about the treating of the pulmonary emboli, which is significant by itself? So beyond the fact that you have to do case by case, what is your opinion? Is there any specific approach to such relatively complex cases that you, if you add to them metastasis to the brain, or like our patient had also history of bleeding, brain bleeding in the past, what do you do? How do you balance those things?
It's a it's a painful point. I will answer about echo surveillance and about management of cancer-related thrombosis. I will ask Dr. Dudnik to help me with that. About echo surveillance, it's my rule of thumb. It's only mine. I cannot show you any data that every 3 months surveillance has any better results than one in 6 months or 1 year survival surveillance. But I think that when you have this kind of dynamic disease, when you are dealing with metastatic disease, and you are treating the patient actually with palliative intent, this is chronic disease, and you have to follow the patient very carefully, because all of us know that only 1 or 2 years ago, we're actually get the first kind of evidence that there is some kind of cardiotoxicity. I mean, in terms of decrease of ejection fraction of Tagrisso. So how it exploded? Because of the close follow-up of these patients. Because in the original studies, there was no data about this. Again, we're in the field that it develops tremendously and very rapidly. And the least we can do as cardiologists to offer as close surveillance as we can do. In my place, I'm able to give the patient every 3 months echo. So I'm doing that. Maybe at other places, the people are not able to do that, or they are, limited by resources or other things. But I think it's makes sense to follow the patients very carefully when you're giving them the new drugs. As you see, that brigatinib was not on board in 2014.
J'ai vu Valérie, j'ai vu le lien. Demain, je vais voir quand est-ce que je peux.
Can you please mute your phone, please?
Zaza.
So, yes. So I think that the case of surveillance, it goes case by case, as you say. And according to the complications of cancer-related pulmonary embolism, I think Elizabeth has better approach to this. How do you manage your patient with cancer-related thrombosis? Do you refer them to a hematologist clinic? You're giving the new oral anticoagulants, or how do you manage them?
Unfortunately, I don't have a good answer for the questions. For these specific questions, we normally it's a risk-benefit ratio. Normally, we approach our hematologist and discuss all these issues with them. But I would like to bring up here the question of whether to perform or not to perform a pericardial synthesis or any other surgical intervention like pericardial damage, because we're contemplating these issues a lot. I just wanted to briefly discuss the goals of such an intervention. And in addition to being a therapeutic one, so it's the first goal, like approaching the patient with a tamponade or pre-tamponade. And as you can also demonstrate, as you can already demonstrate, this patient may live for several years after that. Yeah. So the first goal. The second goal is a diagnostic goal, because by that I mean that we have to differentiate, like in this case, between the malignant pericardial effusion and the treatment-related toxicity. And we know that there were at least several drugs like chemotherapeutic agents like methotrexate and docetaxel, and then biological drugs like osimertinib and skipmatinib, and probably every ALK inhibitor, and then some immunotherapeutic agents like nivolumab. They may cause pericardial effusion, so we have to differentiate between the malignant pericardial effusion and the treatment-related toxicity. By the way, I'm not familiar with any reports of the pericardial effusion caused by lorlatinib, but this is a new drug on the market, and probably it will come later. Like we all know it's a rare type of toxicity, and probably we will see these reports later. And I just wanted to discuss the last diagnostic goal of performing some intervention, some diagnostic intervention like pericardial synthesis or pericardial window, in order to be able to diagnose the molecular mechanism which is responsible for the development of resistance on treatment, because we're facing it every day with patients on the targeted agents. Let's say about 10 or 15% of the patients on osimertinib, EGFR mutant patients on osimertinib, they develop c-MET amplification, and additional 10% of patients develop additional secondary mutation like C797X, and all of these may be targeted with another targeted drug. So probably it's another goal of pericardial synthesis to be able to diagnose all that. So we have to take it into account when discussing whether to perform some pericardial damage or not to do that. And my last point, I would like to just ask, are you familiar with any data regarding any prognostic score for patients with pericardial effusion? Because I'm mindful there's a lot of scores like RPA score for patients with brain metastasis, and on the other hand, I'm not familiar with the scores for patients with pericardial effusion. These patients may live like from several weeks until several years, so it should be developed to guide treatment decisions. What do you think, Dr. Zaza? Are you familiar with that?
Yeah. Then, what do you think? You have a lot of experience in this echocardiography. You followed thousands of patients with pericardial effusion.
Yeah, I mean, for me, basically, I go based on the symptoms. I don't have any scheduled follow-up in my mind anyway. So, because if you look at like the data that you presented, the majority of patients, if they require a pericardiocentesis and you adequately drain it, so you leave the drain in until it's basically dry, that only about a quarter actually occur. So I think that for the most part, it's not a recurrent problem. So I think that echo surveillance is certainly appropriate if you are looking for recurrence, but I would drive the interval of that based on how the patient is doing, or other testing that's done. For example, the CT chest that is done for follow-up of their lung cancer, you'll get an idea whether the pericardial effusion is significant or not.
So Zaza,
So
nice.
multimodality.
It's Joe. Nice presentation. I just want to add that the tamponade is a clinical diagnosis and not an echo diagnosis, so it's confirmatory, but bedside evaluation and follow-up is really important. And we're lucky enough to have a V-scan, a handheld ultrasound, and it makes it really easy to follow effusions as often as you want with every visit. This is probably, of all the things that the V-scan does, this is the best best application.
Yes, I agree with you. Dr. Gilon.
Yes, I have another point to raise, which is a topic within a topic, and it's the other way around. What is the approach to bloody pericardial effusion, let's say large pericardial effusion, with or without tamponade, with no known malignancy? How aggressive should you be in general, and even compared to non-bloody effusion, aggressive in looking for malignancy? Because I think the case reports where it was treated by colchicine, either with or without steroids and non-steroidal. But the question is how long and how aggressive you should be about looking for malignancy.
I actually feel that in this situation that, and it's something that I've noticed, a handful of times each year, is that with some of the factor 10A inhibitors, that they have, the potential of causing a hemorrhagic pericardial effusion. So I've seen a couple of cases each year for the last few years. So I would, if I had another explanation, I wouldn't really pursue a cancer diagnosis necessarily.
But that's a little bit in difference with our approach with anticoagulation, where you have, for example, you have bloody urine, and then you say, okay, because of the anticoagulation, you probably found out that he has some unknown malignancy. So should this be the same approach, or is it different?
No, I mean, I think it's a good point. I would say, I don't know if there would be a blanket statement in terms of always, do this or that for, exclusion of malignancy. But I think, a very careful history and physical, and probably, appropriate imaging would be an initial screen. I think the same thing applies in people that out of the blue develop DVT or PE and,
Okay.
Don't have an explanation. We do know that, that could be the first manifestation of cancer. So at least at some point you have to do a complete history and physical and appropriate imaging.
Yes, I think we're all hinting around puncturing the balloon. The answer is, if it's a bloody effusion, it has to be managed very differently, and it should raise your suspicion until you find the reason why it happened.
Okay.
Thank you. I have one question for Dr. Dudnik. Tell us a few things about lorlatinib, new kid in the block. Only thing that will be interesting for cardiologists, I think that lorlatinib causes elevation of lipids. It's causing even black box for hyperlipidemia, and probably if the patient will be treated long enough, maybe we'll see like a coronary syndrome and like that. Can you tell us what the place of lorlatinib in your toolbox right now? It's a new drug.
Currently we have already 3 generations of ALK inhibitors to approach the patients with metastatic ALK-positive disease, ALK-positive non-small cell lung cancer. The first generation was the crizotinib, a non-selective, I would say, ALK inhibitor, which do not have a good penetration of blood-brain barrier. It's one of the main obstacles for that for these agents. The second generation drugs, and here we have ceritinib, a pretty toxic drug with the hepatotoxicity and the gut toxicity a lot. We do not use it a lot. And then we have alectinib and brigatinib. These 2 agents, they can be, so we can use them or either after failure crizotinib or even as an upfront therapy. And probably the upfront therapy nowadays, it is the preferred type of treatment. And then we have like a 3rd generation of ALK inhibitors, and here we count lorlatinib as the agent with very broad activity against the ALK-resistant mutations as I would say the main advantage, and the second prominent advantage is that this agent penetrates very good the blood-brain barrier, so it may be used in patients, successfully used in patients with brain metastases, and even prevent the appearance of brain metastases in patients with ALK-positive tumors. So these agents originally, it was tested in patients after progression on first and second generation ALK inhibitors, and here we're talking about objective response rate about 30%. So it's not bad, I would say. But then, if we will be using these agents in the upfront setting, in the first one, we will probably get the best results. And here, according to the Brown study, the study which compared lorlatinib and crizotinib, we saw the main advantage of lorlatinib, like progression-free survival advantage, where the hazard ratio was 0.33 or so. And also the prevention of brain metastases. Yeah, these are the good things about the drug. And what are the bad things? Yeah, the bad things, it has the toxicity. And here I would mainly talk about the clinically significant toxicity, and that's the depression and the hallucinations. And it's what I think may be significant from the patient's side. Then we have this fluid retention syndrome, where the peripheral edema, we're facing that a lot. And then we have this laboratory toxicity, what you were referring to, and mainly the hyperlipidemia, which we have to probably do the laboratory testing all the time, but normally it normalizes the appropriate anti-lipid therapy. So it's not the main problem with this drug, as for me. These are the main things. It can be managed. It's a manageable laboratory toxicity, I would say. As opposed to, once again, depression and peripheral edema, which we are facing a lot, and that a lot of times it requires dose reduction, as opposed to hyperlipidemia.
So do you think that in this patient, you will consider the addition of lorlatinib, bringing this back in addition to chemotherapy? Do you consider that?
Yeah, actually, yes. And the main reason for doing that would be to control his intracranial disease, because nowadays, in this specific case, we're switching to chemotherapy, and his CNS disease can get out of the control. So adding lorlatinib on top of chemotherapy would be better for controlling the CNS disease. On the other hand, we do not know what is his pericardial effusion. What is the reason for that? Is it a malignant pericardial effusion, or is it the drug-related toxicity? Because I'm not, I'm really concerned about putting back the patient on the drug, which may cause like pericardial tamponade.
I understand. Then, do you have any insight about the rechallenge of lorlatinib, which is suspected like causing pericardial effusion?
I can't really say that I've ever attributed that to a pericardial effusion. I think that it's probably the underlying disease.
Underlying disease.
Yeah, so I wouldn't worry about it in that sense. I would probably, if you feel like that's the right treatment, then I would consider restarting it.
Yeah, but the main problem that the patient didn't undergo pericardial synesthesis, so we do not know what was the main reason for pericardial effusion. Is that underlying disease, as you already said, the malignant pericardial effusion, or whether the drug caused that.
Yeah, I think the biggest challenge is certainly in the lung cancer space and for pericardial effusions in my book is whether they're on a checkpoint inhibitor or not. Because if they're on a checkpoint inhibitor, then it may be related to their medication and not their disease.
Yes, but we know that, let's say, alectinib and axitinib, other ALK inhibitors, do cause pericardial effusion as a drug-related toxicity. So, you know, the fact that we do not have any data on lorlatinib is probably because lorlatinib is a new kid on the block, and we cannot rule out that.
No, I know, but if you think about it from a term in terms of probabilities, it's a much higher probability that it's related to the underlying disease than it would be due to an EGFR inhibitor or an ALK inhibitor, especially if somebody has lung cancer that's, you know, locally advanced or metastatic.
Yes, this kind of effusion was suppressed by the treatment, you know, during the latter years, and right now we have a gain. So I think we have to assign this to this lung cancer problem and not other drugs. And I think it will be very difficult to re-challenge him by lorlatinib, but it's your privilege, Dr. Dudnik. You'll decide what to do with that, with the patient.
Yeah, I mean, I don't. There's no there's no right answer there. I think the person who's having to make the decision is the one that's going to, you know, put everything together as best they can. So I think, you know, those are really challenging situations, and there's certainly not a known right or wrong answer that I'm aware of.
It's not for both questions, right?
Yeah, yeah, that's right.
So thank you. That's we want to share with you what our thoughts about, and thank you for allowing us to present on this wonderful case webinars, and we'll try to jump on as far as we can. Thank you all, and
Thank you very much.
Thank you very much.
Thank you. Thank you.
Appreciate it very much.
Awesome.
Thank you so much.
Thank you.
Thank you.
Nice day.
Thank you. Goodbye.
Bye bye, guys.
Very well. Nice job.
Thank you. Thank you. Good presentation. Thank you.
Thank you. Thank you.